chunk of this today, probably not all of it. There's a lot here. Although hemolytic anemia is kind of is one category, it has quite a few subcategories, and each subcategory has subcategories. So this one's pretty hefty. I leave it for the end. Just I don't know why. If you think it would be better somewhere else when you do your evaluations of the class, let me know. That's how I learned to teach, was by listening to what my students told me. So,
Hey, Deshaun.
is it plugged in? Is it turned on? Okay. All right, erythrocyte metabolism. This slide should look familiar, as in it's copy-pasted from another lecture we already had. Smile, nod, okay. So this is basically, the reason we're representing it again is because what results when we have a problem with our enzymes is we wind up with a hemolytic anemia. Okay, so this is the first class, is an enzyme-regulated hemolytic anemia. Okay. The most common of these is G6PD. I've never seen the hexokinase, and I think I've seen one case of pyruvate kinase. They're just not a real common kind of thing. The other piece that we need to talk about is the membrane of the erythrocyte. It is a basically bilayer of phospholipids and proteins. About 40% of it is lipid, about 2% is protein, about 8% is carbohydrates, and that ain't near 100%, but that's okay. But it's made up of basically lipoproteins. It has a very selective permeability. So it lets water and anions enter freely. What is an anion? Negatively charged ion. It does not allow cations, or positively charged ions, to go back and forth freely. It requires a active transport to transport cations back and forth across the membrane. It allows for gas to come in and out, especially oxygen, because if oxygen can't get out of the cell, sort of defeats the purpose of the erythrocyte, doesn't it? It needs sufficient generated ATP to perform what little function it has, and that's primarily transport stuff across the membrane. Okay? So it requires a little bit of ATP, even though the cell is not, technically alive. The nucleus is gone. It doesn't do protein creation or anything like that, but it does require a little bit of ATP, and most of that is generated by anaerobic glycolysis. Okay. Anaerobic glycolysis is significantly less efficient. It produces less ATP than does aerobic glycolysis. But if our red cells were using up all the oxygen for aerobic glycolysis for themselves, they wouldn't share very well, would they? What other things does the membrane do? It maintains the cell shape. Yes?
And both mean without, so does that word not mean something? Aerobic, anaerobic?
Aerobic is with air, anaerobic is without air. The AER is air,
Okay,
or
so
oxygen.
It's not A or
Maintain shape. It provides a supporting skeletal structure. In other words, if you didn't have a cell membrane, you'd just have this stuff floating around. It wouldn't have any shape. Okay? It aids in the transport of essential ions and gases. There is an active transport for sodium and potassium, and passive transport, which is just simple diffusion. Okay? One of the things that this comes up for us is if you don't have, you have to spin down our chemistry tubes, right, and many of our other tubes. Hematology tubes, you can throw them right on the analyzer. The thing is, sometimes you need to let them sit for just a minute. So if you have flags and they're kind of funky, just let them sit there a minute and then put them back on. You need to let the ions kind of and the water sort of settle, let it come to a nice equilibrium state. And sometimes when you put it directly into the EDTA, if you get it fast enough to the analyzer, sometimes it didn't sit well and the red cells haven't quite equilibrated. So sometimes it gives you a little trouble. Big trouble? No, nothing major. It just looks kind of funky. What happens as they get older? You know, just like everything else, cells age. Well, they just don't hold up like they used to. They have less energy, i.e. they have a decreased generation of ATP. Less of selective permeability, okay? The lipids tend to break down, and stuff can't go back and forth through the membrane quite as well as it used to. They tend to get more spheroidal in shape. They're not as bendable, not as flexible. Again, just like old people, they don't bend and flex and change as well. The internal metabolic activities begin to shut down. They only can go for so long before just the chemical reactions no longer occur easily. And we'll see intravascular and extravascular hemolysis of these older cells. And we'll talk more about that in just a moment. Like now. Extravascular hemolysis. Extra means outside. Vascular means what? What? What space? Within the vessels. So extravascular means outside of the blood vessels. Okay. About 90% of all red cell degradation occurs in the extravascular system, primarily the spleen. This is the spleen's job. It pulls out the old, dead, dying cells and breaks them down. Does anybody remember what I told you about free-floating hemoglobin? Does it work? No. It not only doesn't work, it's what? It's toxic. Okay. This keeps us from having free-floating hemoglobin. Okay. So it pulls the cells out before it tears them apart so that you don't wind up with a lot of just loose hemoglobin floating through your system, which would kill you. It will eventually shut down your organs. So in the spleen, the phagocytosis, the cells in the spleen grab the cells, okay, pull them in. Sometimes the spleen will just pinch off a bad spot. That's why the blister cells, you'll see those, it looks like somebody took a bite out of it. Well, that's what happened, is that the spleen said, well, this one's okay, but we're just going to take that bad part off of it. The hemoglobin is disassembled. The iron is bound to transferrin to go to the storage pools in the liver. And then the amino acids are broken down and stored in the liver as well. All of our amino acids wind up in the liver because that's where most of our protein generation is. Okay. So the hemoglobin is torn back down. The protoporphyrin ring, okay, is separated off. Any CO2 is exhaled. That means it goes into your blood system, goes to your lungs, and you breathe it out. Jean will go into this much more, but the pyrrole ring, that's the outer ring without the iron in it, okay? So basically, it goes to the wrecking yard, the spleen, it pulls it out, tears it apart, takes the globin chains, pops all those little amino acids off and sends those to the storage pool. It takes the iron out of the pyrrole ring, out of the protoporphyrin 9 ring, and sends it over to be stored. Then it has this leftover organic structure that it has to break down. So what it does is it converts it to something called biliverdin. Okay, and just like I told you, there's a whole slew of steps in making the protoporphyrin ring that I'm not going to make you learn. There's a whole slew of steps in the breakdown of the protoporphyrin ring that I'm not going to make you learn. That's Jean's job when she talks about porphyrias. You're going to bind it with albumin, which is just the primary protein that is in your body, and it's going to take that to the liver. In the liver, it's going to take this biliverdin and conjugate it to make bilirubin. Conjugated bilirubin. Okay. That is then going to go into the intestine through the bile duct and you're just going to expel it. It's converted by intestinal bacteria into urobilinogen and urobilin, and then it is excreted in the feces. Some of this urobilinogen is reabsorbed back into the system, and it winds up going to the kidneys and being filtered out there. Why is that important? Because we measure that on our urine dipstick. If your liver isn't functioning properly, you'll get increases of this urobilinogen and increases of bilirubin in your bloodstream. Normally that should not be high, it should be very, very low. Bilirubin is even more toxic than hemoglobin. Thank you. Brain cramp. Okay, so this is a very important process that we make sure that pyroid ring doesn't just float around. Extravascular hemolytic anemias. You can have inherited defects such as membrane abnormalities. This is the first set of subcategories. You can have enzyme deficiencies, hemoglobinopathies, and thalassemias, which we already talked about in depth. So actually, hemoglobinopathies and thalassemias are technically hemolytic anemias. So when we talk about separating out, we can either separate by micro, hypo, macro, normo. Okay, we can separate them out based on the indices. Does anyone remember the other way we can separate out the anemias? There was another classification system. The pathophysiologic system, where you're either not making it, you're losing it, or you're not making it correctly. So when we get into the losing it, you can have your non-hemolytic and your hemolytics. Your hemoglobinopathies and thalassemias actually fall within the hemolytic group. But we've already talked about those, so we're not going to talk about those anymore. You can have acquired RBC deficiencies, such as the megaloblastic anemias. We already talked about those as well. Okay. We also see a newborn vitamin E deficiency. Vitamin E is incorporated into a lot of the cells in our body. It has a lot of protective functions, makes them stronger, makes them work better. So most newborns in the United States get a shot of vitamin E. That's just part of they get a shot of vitamin E and a shot of vitamin K. That's just kind of part of neonatal care. It doesn't take much, it's cheap, and it prevents a lot of problems down the line. So really, our vitamin E deficiency, this we're going to see in developing areas or medically underserved areas where the children aren't treated as soon as they're born. We can have immunohemolytic anemias. This is where your immune system decides it doesn't like your red cells and it pops them. Okay. We can have an autoimmune anemia. Basically, for some reason, your body doesn't like it, makes antibodies to your red cells, and just pops them for no really good reason. It decides your red cells are the enemy and must be destroyed. This is not healthy. We can have drug-induced anemias. That's usually part of our immunohemolytic anemias. Certain people are sensitive to certain medications. Chloramphenicol is one of them that I know off the top of my head that does it. That you give a patient this drug and all of a sudden all of their red cells start popping, their hemoglobin drops, they have in vivo hemolysis. Okay, in vitro hemolysis is when you draw it and it's red and cherry, or when we put it in the hemolyzer in the lab. At least that's what the nurses say we do. But in vivo hemolysis means it doesn't matter how well you draw it, it's going to be hemolyzed because it's hemolyzing in the body. Intravascular hemolysis, every once in a while, our nice little red water balloons that are floating through our system, they're just going to get kind of hung up and they're going to pop and they're going to release their hemoglobin into the intracellular space. Intracellular space. Okay, so within the vessels, we know that hemoglobin, free hemoglobin, is toxic. So we have a compound in the body called haptoglobin. And haptoglobin's very important to us when we're talking about hemolytic anemias, because what happens is as soon as hemoglobin is released, this haptoglobin, that's like buffet time. It goes over there, it grabs it, and it just munches it right up. It binds it up so that it cannot bind or interfere with other cells. So this haptoglobin is going to bind our free hemoglobin to keep it from being toxic. Iron is bound to transferrin, so the iron's going to get let loose and it's going to go and be stored. And the protoporphyrin is degraded in the liver normally. Okay, so this haptoglobin takes it down to the liver, which tears everything down and stores it the way it's supposed to. Yes.
Do we only have so much haptoglobin, and so that's why the hemoglobin is toxic, because it can't handle too much of it?
Right. We have a limited amount of haptoglobin, and once it's full, then we got problems. Exactly. The things that cause severe intravascular hemolytic anemias tend to be complement activation on the RBC membrane, and this is another one of those kind of circular discussions. I'll tell you all about complement when we hit serology. But basically what happens here is it binds these proteins to the outside of your cells. Paroxysmal nocturnal hemoglobinuria, we're going to see an increased osmotic fragility, and we've talked about osmotic fragility before. What is osmotic fragility? This is the third time we've had this discussion. It's going to be on the test, don't you think? Yeah.
It's the amount of like fluid that the cell can take before it bursts. So like it's a little bit more strict on how much it can take before it bursts, either one way or the other, increase or decrease the fluids.
Right, exactly. If I put, when I suspend my red cells for my red count, what do I put them in?
You put them in saline.
Put them in saline. More specifically, I put them in normal saline, or 0.9% saline. Okay. If I put it in 0.8%, it's probably going to be okay. As I lower that percentage, slowly lower that percentage, the lower the percentage of saline, the higher the amount of water. At some point, it's going to be more like water than saline, and it's going to burst your red cells, right? Osmotic fragility is how low can I go with that percentage of saline before these cells start popping. So what happens in this paroxysmal nocturnal hemoglobinuria, or PNH, is these cells are more susceptible. They can't handle osmotic changes in our body. And actually when you sleep, there are quite a few changes that occur. And one of them is a little bit of osmotic change. Not much, just a little bit. But if these cells are particularly fragile, they can't handle that change. Paroxysmal cold hemoglobinuria, well, guess what makes that one bust?
Cold.
Yeah, don't make this harder than it is. Cold. Okay. I'm just making sure you're awake. Specific auto or alloimmune hemolytic anemias, we're going to talk about those a little bit more. This would be like a transfusion reaction in blood bank. So I'll get a little bit into that now, and I'll let Barb get a lot into that coming this spring. We can also have a hemolytic anemia due to physical or mechanical trauma. The microangiopathic hemolytic anemias, we'll talk about those. There's a bunch of them. Just that would be something like your heart valves, things like that. Osmotic trauma, this one doesn't happen very often, thank God. If somebody hangs water instead of saline in your IV, the newer IV bags are clearly labeled. The newer water things are clearly labeled. Do not infuse. Big, huge signs on them that says, don't give this to a patient. I guess it used to be a thing. Insertion of prosthetic valves, if they put a valve into your heart and it doesn't work quite right. DIC will also cause these mechanical problems. Because if you remember, schistocytes is one of the signs of DIC. Yes?
So when they're giving you fluids to rehydrate you, they're giving you saline, not H2O.
Yeah, they're giving you saline. If they're putting it directly in your vein, they better be giving you saline. Otherwise, they're just turning your blood into sheer hemolyzed, and they'll kill you. So, yeah, they're giving you saline. Specifically, normal saline, 0.9%.
5% saline.
Huh?
I thought it was a 5% saline.
No, 0.9. 0.9. Otherwise, it will kill you. I can't believe I have another typo, darn it. I'll just try and remember this one. A toxic environment. That's supposed to be environment. Bacterial infections. The bacteria can cause your body. Thank you. Trying to get all the typos out of here. Bacterial infections, your body's kind of running amok, and it can actually cause your red cells to hemolyze. Malaria will cause your red cells to hemolyze. That's part of their life cycle. They get within your red cell, they multiply, they burst the red cell to let themselves out, and so on and so on. Drug poisoning, drug or drug poisoning. In other words, you give a chemical of some sort and it causes hemolytic anemia. I guess this also would be where we'd find venoms like, rattlesnake bites and things like that. Lab findings in vivo hemolysis. In other words, when the hemolysis occurs inside the body. All right. If we get a hemolyzed specimen, what we're going to do is redraw it. And if that doesn't work, we're going to have somebody who's good redraw it. And if that doesn't work, we're going to have somebody with a big needle redraw it to make sure it's not hemolyzing because of the draw. But once we've determined that the hemolysis is actually in vivo, we're going to start looking. In intravascular hemolysis, the key that we're looking for here is that haptoglobin. Okay, we're going to measure the haptoglobin to see if it is going down. So if our haptoglobin has dropped, we have intravascular hemolysis going on. The formation, we're going to look for methemoglobin and methemalbumin. Okay? Basically, these are compounds that come up in intravascular again. Honestly, I've never seen anybody measure those. I've seen people measure this one a lot. Okay, so we do know that methemoglobin and metalbumin are made when intravascular hemolysis occurs, but basically we measure the haptoglobin. It's easier. We're going to see an increase in bilirubin, both direct and indirect, and we're going to see that in both extravascular and intravascular. The bilirubin's going to go up. Why? Why is my bilirubin going to go up if I've got hemolysis going on? Right, because I've got increased destruction of the cells, so it's got to process that extra released pyrrole ring. We're going to see an increase in iron stores in both for the same reason. My hemoglobin is being released from the cells, torn down, and the components are being spread where they belong. So my iron stores are actually going to go up. I'm going to see an increase in LD isoenzymes 1 and 2 only in the intravascular. And if I'm looking for intravascular hemolysis, we measure the haptoglobin and the LD. These are the two you actually will see, and I will let Miss Barb go more into what lactate dehydrogenase is. Okay? We're going to see an increased reticulocyte count. Why?
Because your body's destroying your cells, so it's making new ones.
Your body's destroying the cells, so it's got to make new ones so you don't die. Okay? Hyperplastic bone marrow, the same thing. Okay? We're going to see an increase in bone marrow activity because you got to have new cells. We're going to see an increased plasma hemoglobin only in the intravascular. Okay? And what that means is that if I take the blood and spin it down and measure just the plasma, my hemoglobin should be essentially 0 in the plasma. Okay? I'm going to see increase in the hemoglobin in the plasma. That just makes sense, right? All right, the first subcategory of the subcategories. The first cause of hemolytic anemia is membrane abnormalities. Your red cells are not structurally correct. Okay. These tend to be inherited. They tend to be autosomal dominant. What does that mean? What does autosomal dominant inheritance mean? Only one parent has to have it. You've only got to have one copy of the bad gene for it to be expressed. Okay. So you only got to have, so this is worse because everybody who has it can pass it on to their children. And if they get one copy of the gene, doesn't matter if they've got a good copy from the other parent, the one copy is enough to give them the disease. Basically what happens here is we see a decrease in RBC membrane deformability. All right, remember for a red cell to go through the vasculature, to go through those little teeny tiny capillaries, which are about the width of a red cell, actually a little smaller than the width of a red cell, it's got to kind of blob through there. It has to be able, it's just floating along. To get in through the membrane, it has to be able to kind of stretch and ooze and deform itself to get through. If it can't deform, it can't get through there. So it's going to burst. And that's usually going to happen in the spleen because that's the spleen's job. Anything that can't wiggle its way through the capillary bed nicely, it says, you're old, you're no good anymore, I'm going to execute you. Okay, so it's going to get rid of the old deformed cells. The problem is, if all of your cells can't get through there, it's destroying all of your cells. Okay? So we're going to see an increase in extravascular hemolysis. You need to know for each of these different types of hemolytic anemias, which are extravascular, which are intravascular. Which do you think health-wise is worse for you? Intravascular is significantly worse. Okay. The findings are going to vary with the severity of the anemia. If it's just a little bit, you're going to be mildly anemic. Okay. If it's really bad, you're going to be severely anemic. Okay. One of these days, I'll get rid of all of the typos. So slight to whatever that word is, symptoms of anemia. Depends on how bad the anemia is, what your symptoms are going to be. One of the big things to remember here is jaundice is going to be one of the big clues on these hemolytic anemias. And what is jaundice? Say it again. You get yellow. Your skin, your eyes. Okay. What causes jaundice? Increase in bilirubin, which is a result of the liver not functioning properly. Okay. We've got increased breakdown of hemoglobin, which is going to give us increased levels of bilirubin, which is going to give us yellow people or orange. Yes.
Isn't it also because of vitamin D deficiency? Isn't that why they tell you to throw your baby out in the sun?
Yeah.
So they can do
Yeah. We'll talk about that when we get to the evidence, okay? The other thing we're going to see here, this is important because it is extravascular hemolysis. Where does extravascular hemolysis occur? In the spleen. So the spleen is going to be doing its job. It's going to be bulking up so it can do its job. So we're going to see an increase in its size or splenomegaly. So in extravascular hemolysis, we're going to see splenomegaly and we're going to see jaundice. And again, how much is going to depend on how bad the hemolysis is. Sorry, I didn't know it was locked. is going to depend on how bad the hemolysis is. This is going to be a normocytic normochromic anemia. Okay, basically, your cells aren't going to be any different in size. They're going to be a normocytic, they're going to be normochromic. It can eventually lead to a slight hyper or macrocytic hypochromic, but we're going to see increased reticulocytes. We're going to see increased reticulocytes in all of these hemolytic anemias. Okay, if we don't, what does that tell us? The what?
So it's not hemolytic.
Not exactly that it's not a hemolytic anemia, but that it's not only a hemolytic anemia. Eventually, some of these hemolytic anemias, the bone marrow just works so hard that it wears out and it says, I give up. So then you wind up with a hemolytic anemia complicated by bone marrow failure. So I said the problem is these anemias are not discrete. You can have more than one of them at the same time. You can have a hemoglobinopathy B12 folate iron deficiency anemia. Yeah. So they don't always, do things one at a time. The poikilocytosis is going to be related to the exact disorder. Remember, we're talking about membrane abnormalities. So what is a poikilocyte? An abnormally shaped red cell. Right. Other lab findings, we're always going to find an increase in bilirubin. Okay. Increased breakdown of hemoglobin equals increased bilirubin. We're going to see, again, an increase in iron stores because it's been freed from the hemoglobin. And about 70% of your iron is normally stored in your hemoglobin. Well, if it's released from the hemoglobin, your body's going to store it somewhere else because remember, it has no way of getting rid of it. Hereditary, oh good, I got rid of my hereditaries. These all used to say hereditary. I forgot E. Hereditary spherocytosis. I wonder what shape the cells will be in hereditary spherocytosis. Don't make these harder than they are, okay? This is an abnormality of the membrane proteins themselves. It is a spectrin deficiency, and spectrin and sphingomyelinase are the two main components of your RBC membrane. And what happens here is that instead of being a nice deformable little ball, your red cell is a perfect circle. So it can't get through those capillaries quite as well. We're going to see an elevated MCHC, although what does normally an elevated MCHC mean? Lipemia, okay. In this case, yes, you will see an elevated MCHC. How common do you think this is? On a scale of horses to zebras, this is definitively a zebra. Okay. We will see a hyperchromic anemia. We're going to have spherocytes on the slides. Definitive increased osmotic fragility. Because if you think about it, okay, normal red cells like this, and as the water content of the external environment goes up, it starts to take water in and it starts to swell, right? And eventually it swells until it's nice and round. And then if the water content still goes down, it can't swell anymore and it's going to pop. These guys start here. So they can't pull in much more water or they burst. Okay? The treatment for this basically is splenectomy. You take out the spleen so that it's not removing as many of the cells. You're still going to have some hemolysis. There are other extravascular pathways. But for the most part, you just wind up with a mild anemia. Yes?
Does your liver take over the spleen's job or attempt to?
Part of it, yes. It can't do it as well. But that's why you can live without a spleen.
So any that the treatment is a splenectomy is extravascular problem?
Yes.
Okay.
Yeah. And vice versa, in most of our extravascular hemolysis, the treatment is splenectomy. Okay. Hereditary elliptocytosis. Gosh, I wonder what shape the red cells will be. Again, it is a normo. We're going to see lots of ovallocytes. It will have normal osmotic fragility. Okay, they're like this. Okay, so they're not donutted, but they're like this. So they still have quite a bit of room to swell. Okay, so we're going to see a normal osmotic fragility in these. Hereditary or related conditions: hereditary spherocytic elliptocytosis. Okay, these would look like that. Okay, where they have no central pallor and they're still kind of oval. So it's two bad things together that doesn't make for happiness. Pyropoikilocytosis. We actually had this one. Scared the bejesus out of all of us. Anybody remember what I told you? What's a normal newborn hemoglobin? That's the MCV.
29?
What was it?
29?
20. Not 29 is a little high, but yeah, in the 20s. Okay. Normal newborns have a hemoglobin somewhere between 15 and 25. We'll just make a big range there. But it's up in the 20s. We had a baby came in had a hemoglobin of 7. Uh-oh. Who drew that wrong? So we had it recollected. No, the baby really was 7. You put it under the microscope. If there is a poikilocyte out there, it was in there. We had schistocytes, we had ovallocytes, we had target cells, we had, I don't know, you name them, it was in there. We had duck cells, we had gopher cells, I mean, goldfish cells. They're all in there. Those last 3 are not real ones, by the way, just saying. But we had all kinds. It was horrendously ugly. It is more prevalent in African Americans. Gross poikilocytosis. I mean, if I could have called a 12 plus poik on this thing, there was not one single normal red cell anywhere on the slide. Severe decrease in MCV, extreme increased osmotic fragility, and especially thermal sensitivity, which means in this weather you would not take that baby outside. If the baby gets a fever, instant hemolysis. So, but they told us that she'd grow out of it by the time she was 6 or 7. So I don't know. I was unable to follow up any further than that. It's ugly. I mean, and we're all like, oh, look at this. This is really cool. Not good for the baby, but we shipped her over to Children's, and it's one of the few times that we actually heard back. A lot of times we'll ship them over and we'll ask, hey, let us know, and nobody ever tells us what happened. But this one, they actually sent back the report on it, and basically because it was a very rare thing, and it was kind of cool. We got to see it. Hereditary stomatocytosis. This one is a failure of the sodium-potassium pump, okay? So it leads to increased water in the red cell, because remember, to balance out water diffusion, or osmosis, what we do is we balance out our cations and our anions. If our biochemical pump cannot take the cations in and out of the red cell, then we're going to wind up with an electrolyte imbalance, and we're going to wind up with water flooding into the cells. This is usually caused by what? Stomatocytes are usually caused by what? It's an artifact. It's usually an artifact. So if you see all stomatocytes, what's the first thing you're going to go do? Make another slide to make sure that it wasn't just the way you made the slide the first time. We're going to see a macrocytic anemia. The stomatocytes tend to be macrocytes. We're going to have an increased potassium and a decreased sodium, because the potassium is normally transported into the cell and the sodium is normally transported out of the cell. So since we can't get the potassium and the sodium in and out, what we wind up with is increased potassium in the blood and a decreased sodium because it's in the red cells. We're going to have an increased osmotic fragility. This is associated also with an Rh null blood type. I'll let Barb get into that with you. It means it doesn't have any Rh antigens on it. So it will be D negative, big C, big E, little e negative blood. It's, when you talk about rare blood types, it's really rare. Acanthocytosis, this is basically a beta lipoprotein. You're missing beta lipoproteins. This one is autosomal recessive. This one is different. The others are autosomal dominant. This particular one is autosomal recessive, which means we're going to see it even less commonly because you have to have 2 bad copies of the gene for this to happen. We're going to see an abnormality of membrane lipids that leads to these bizarre, weird shapes. Okay. This is also what we're going to see in vitamin E deficiency in infants. Okay, but again, that's why I said it's pretty much standard practice in the U.S. to give them a nice shot of vitamin E to get them going. So far, so good with the inheriteds. Okay, so the ones we just talked about, the stomatocytosis, the spherocytosis, the acanthocytosis, and the elliptocytosis, those are all inherited. There's nothing you can do to fix them. Your body's not making the cells correctly. You can't make it better any more than you can fix sickle cell. Okay, it takes a total overhaul of the entire mechanism of erythropoiesis. Okay. Why would we not do a bone marrow transplant on a patient who had one of these hereditary hemolytic anemias? Because the risk of the transplant is significantly greater than the morbidity of the disease. Acquired membrane abnormalities. Okay, that's going to be our PNH and our PCH. For some reason, these cells have an increased sensitivity to complement. And again, we're going to talk about complement a lot more in serology. But what it is it's a cascade of proteins that basically coat your cells and tell the spleen, hey, this needs to be removed, it's cruddy. It kind of goes along and marks them and says, take this one, take this one. And for some reason, your cells become overly sensitive and the complement makes them all burst. You get anything from a mild to a severe aplastic anemia. And aplastic anemia means you don't make more either. We're going to see an increased reticulocyte. That is wrong. That is just really wrong. Mark out aplastic. I need to look at that. I don't know why that says that. I don't know why I didn't catch that before. Increased reticulocyte count. The key here is that it's nocturnal. You wake up in the morning and you pee blood. When you wake up in the morning, your pee will be bright red. The rest of the day it may be fine, but after you go to sleep and then wake up, you're going to pee out bright red. You're going to have hemosideruria, which means I'm going to have hemosiderin or iron deposits in my urine. Why? Well, because I got all that blood in there. Okay. This one is associated with a HAMS test. Okay. Paroxysmal nocturnal hemoglobinuria is associated with a HAM test. And what we do with that one is we take the patient's blood and we put it in a sucrose solution and we use acidified serum to see if these things will lyse. All right. How do we treat it? We just treat the symptoms. We give you nutritional support, B12 folate. Yes.
What did you say the P was?
Paroxysmal. If it gets really severe, we may give you a blood transfusion. But for the most part, we pretty much just treat them symptomatically. I do believe they were using plasmapheresis at one point on this, but I don't think I ever read anything on the follow-up studies whether it actually worked or not. And plasmapheresis is basically where they take your blood out of your body, take your plasma off, and put somebody else's plasma on there. Again, I didn't read the follow-up study, so I don't know whatever happened with that. Again, this is definitely a zebra. Okay, this is not where you're going to go first. Enzyme deficiencies. This is the next category. These are also going to be inherited. G6PD, which is glucose 6 phosphate dehydrogenase. I'll get it all out there. And how do you spell that? G6PD. Okay. It is X-linked recessive or codominant. What's that mean? I mean boys is going to get it more than girls. Because boys only get one X and girls get 2. It is asymptomatic. You absolutely positively will not ever see this unless they're treated with certain medications. One of those being vincristine, which is what we use to treat acute lymphocytic leukemia. So anytime they're going to give a patient vincristine, they do a G6PD analysis to make sure that they're not going to send them into a severe hemolytic anemia. And as in severe, I mean it bursts like almost all the blood in your body pretty much simultaneously. So that's bad, by the way. So they test you for that. The other thing is fava beans. I don't know why, but there's some chemical in fava beans. People with G6PD, if they eat fava beans, will have a hemolytic anemia. So we know Hannibal Lecter was not G6PD positive. Findings in a crisis, we're going to see intravascular hemolysis, massive intravascular hemolysis, as in you spin down the blood and you can't tell what's the cells and what's the plasma. Okay. We're going to see jaundice. All of our hemolytic anemias are going to give us jaundice of some degree. Okay. Hemoglobinuria, what does hemoglobinuria mean? Bloody pee. Okay. We're going to see Heinz bodies. These are precipitated denatured hemoglobin. And where am I going to see Heinz bodies? I'm going to see them on a retic slide. It's the only place I will see them. You do not see them on a peripheral smear. You see them on a retic slide. They stain with the supravital stains. So G6PD is asymptomatic, except drugs and fava beans, and Heinz bodies. Those are kind of your pieces to pick out for G6PD. Pyruvate kinase severity varies from severe neonatal anemia to totally asymptomatic compensated anemia. Okay, your body can compensate for increased hemolysis. It just steps up the production a little bit, especially these extravascular hemolytic diseases. We're going to see a normochromic normocytic anemia. What are we going to do? We're going to give them support therapy, splenectomy if it is severe. And generally it's not going to be severe unless it is autosomal, unless it's homozygous. All right. And then, let's see, how much more do we have to go on? Yeah, I think we're good for today. Okay, we'll finish up tomorrow. I'm going to go find Barb. She's going to talk to you about your first chemistry assignment, which is posted on Blackboard.